Hi, I'm Bill Wiley.
I'm Stephen Dell.
And I'm Rob Weinstock.
And we're the co-chief medical editors of Cataract and Refractive Surgery Today.
Hey listeners, thanks for tuning back into CRST the podcast for our second episode. I hope you liked what you heard in the first, and we have plenty more in store for you today. I'm Laura Straub, Editor-in-Chief of CRST. In each episode of the podcast, we'll hand-select a few articles from the current issue to share with you on the go, whether you are at home, in your car, or trying to squeeze in a quick walk or workout. We have some pretty interesting articles to share with you from the July issue here on CRST the podcast, so let's get started. The first is an article on the evolution of steroid use in anterior segment surgery. Let's listen in as Damien Goldberg, a partner at Wolstan and Goldberg Eye Associates in Torrance, California, discusses the advances in drug dosing and delivery in cataract surgery.
Steroid medications are an integral part of how we care for patients after cataract surgery. I can still recall the drop packs my attendings used to give our cataract surgical patients when I started residency. Every patient left with a post-op pack containing an eye shield, sunglasses, an antibiotic, a steroid, and an NSAID drop. Prednisolone acetate ophthalmic suspension 1%, predfortate by Allergan, was a popular choice for the steroid, and ketorolac tromethamide ophthalmic solution 0.5%, Acular by Allergan, was a popular choice for the NSAID. Strong empirical data supported the use of both steroid and NSAID as a significant way to reduce the potential side effects of cystoid macular edema for cataract surgery. However, prescribing triple eye drop therapy had its issues. Not every patient was willing or would remember to use all three medicines 4 times a day. Not to mention 268 drops on the eye, assuming the antibiotic is taken for a week. The steroid and NSAID are each taken for 4 weeks from 3 different bottles with 3 different preservatives was rough on the cornea surface and complicated the healing process. Since that time, through advances in drug delivery and posology, the drug schedule for both antibiotic and anti-inflammatory drops have been significantly simplified. Difluprednate ophthalmic emulsion 0.05%, Durezol by Alcon, was the first steroid that allowed us to reduce dosing. It was shown to have double the potency of prednisolone acetate and remains the most potent topical steroid in our arsenal. It can be dosed 3 times a day rather than 4 times a day. Some even dose it twice a day. More recently, 2 formulations of lotoprednol etabonate, a softer steroid, have become available, and each helps to improve bioavailability in different ways. A gel formulation, lotoprednol etabonate ophthalmic gel 0.38%, Lotamax SM by Bausch & Lomb, increases resident time for the drug. And a formulation using nanoparticles or mucose-penetrating particle technology helps the drugs penetrate to target tissues better. And a formulation using nanoparticles or mucous-penetrating particle technology, a lotoprednol called Invelitis by Kala, uses the nanoparticle mucous-penetrating technology. Both these lotoprednol formulations can be dosed twice a day. Another familiar formulation, fluomethanol acetate ophthalmic suspension 0.1%, Flarex by Ivance Pharmaceuticals, has had a resurgence and gained popularity. These medications decrease the frequency of steroid treatment, but navigating 3 different post-op medications remains a compliance and cost barrier for many patients. Many physicians who have previously preferred to prescribe brand name drugs, many physicians who may have previously preferred to prescribe brand name drugs have noted the burden of prices in the current complex healthcare landscape. In the search for alternative solutions, many practices have begun routine use of compounded combination topical steroids, antibiotics, and NSAID medication. One option is prednisolone phosphate 1%, gadafloxacin 0.5%, bromfenac 0.075%, Omni by OSRX Pharmaceuticals can be prescribed 3 times a day for a month. The advantage of compounded approach include improved patient compliance, preventing health plans or pharmacies from changing or denying prescribed medications, and eliminating staff time spent dealing with callbacks from healthcare insurance plans. Additionally, compounded drops can considerably lower patients' out-of-pocket costs. Moreover, in one study found that inflammation was reduced in patients treated with a compound combination. In a randomized double-masked prospective U.S. multicenter study, an earlier version of Omni by OSRX demonstrated a 50% reduction in some ocular inflammation score compared with a 23% reduction in control patients using Predfortate, Vigamox, and Alevro. The success of the compounded drops have been attributed to the innovative simplicity of freeing patients to administer fewer drops postoperatively. Some cataract surgeons have also begun using compounded intracameral injections of a corticosteroid and fluoroquinolone antibiotic combination, dexamethasone phosphate 0.1% with moxifloxacin 0.5% sterile ophthalmic injection, Omni intracameral injection by OSRX Pharmaceutical. In the past, we have also seen the introduction of 2 extended release options for steroid drug delivery that look promising to treat postoperative inflammation. The dexamethasone ophthalmic insert, 0.4 milligrams, Dextenza by Ocular Therapeutics, is an intracannular corticosteroid insert placed in the punctum. Dexamethasone intraocular suspension, 9% Dexacu, is an intracameral option as well. There is a great deal of enthusiasm to see the development of new steroid drug delivery options such as these, but working through the details of the cost barrier with these new drug delivery options can be challenging. Once drug coverage for these agents is widely established, it will no doubt lead to greater adoption. The traditional regimen of prescribing steroid eye drops remains the main method of postoperative cataract surgery care, but new technologies and compounded formulations, such as those described here, offer great promise.
Thanks, Dr. Goldberg. You can also read about the evolution of steroid use in refractive and glaucoma surgery by visiting our website or checking out your latest print issue. Next, let's hear from Denise Visco, President and Medical Director of Eyes of York in Pennsylvania, as she shares why she's done away with drop regimens, which has some extra benefits now during the COVID pandemic.
Before the COVID-19 pandemic, our practice was already moving toward minimizing perioperative drop regimens for cataract surgery with the goal of improving patient compliance. Concerns surrounding the pandemic have pushed us to eliminate drops altogether. Let me explain how we got here. Regarding antibiotic use with cataract surgery, before the pandemic, our surgeons had concerns about replacing the branded topical formulation we had been using with intracameral compounded moxifloxacin only. Surgeons were using intracameral moxifloxacin, but still prescribing topical antibiotics perioperatively. Anti-inflammatory agents were a different story. When phenylephrine ketorolac intraocular solution became available at our ambulatory surgery center several years ago, we dropped topical steroids from our cataract protocol. This made life much easier. No complex tapering schedules for patients, and no chasing down the appropriate formulary steroid product. Thus, even before the pandemic, our cataract surgery patients used only topical NSAIDs and antibiotics perioperatively. Bromfenac ophthalmic solution and besofloxacin ophthalmic suspension were each used twice per day for 2 days pre-op, and besofloxacin was continued for 1 week, with Bromfenac 4 weeks postoperatively. We did a retrospective study of our patients before and after this change and found that patients receiving intracameral phenylephrine ketorolac had a lower incidence of CME, pain, and breakthrough iritis postoperatively than those receiving the topical steroid. Not only did our new protocol maintain our positive patient experience, we improved it. With the advent of 2 sustained delivery steroid products, the intracameral dexamethasone intraocular suspension and the intracanalicular dexamethasone ophthalmic insert, we began considering a return to steroids for postoperative inflammation control if we could forfeit that topical NSAID. The primary advantage of this change obviously would be eliminating another product that depends on patient compliance. An additional advantage, however, would be decreasing the burden of patient prescriptions on our practice workload. For reference, when we discontinued topical steroids, we cut this workload by a third. We could potentially decrease the burden by an additional third, leaving only that topical antibiotic. We began using the intracanalicular dexamethasone ophthalmic insert for patients with insurance coverage. And then COVID-19 arrived. Patient safety issues now include limiting visits to the office and to pharmacies. Full and hybrid telemedicine examinations are a new normal for our practice. The administrative burden of office visit maintenance and documentation has increased dramatically. Ironically, we must do less with more. The reservations we were holding on to no longer seemed relevant. Consequently, we've embraced a drop-free regimen. This approach philosophically hits all the new post-COVID benchmarks of patient care. We have discontinued topical antibiotics and topical NSAIDs. We prescribe bromfenac twice per day, only if patients cannot have the intracanalicular dexamethasone insert or they are at high risk for CME postoperatively.
Thanks, Dr. Visco. She was one of 7 surgeons who shared their pre- and post-op drug regimens with our readers this month. Are you curious about 3D digital visualization systems for anterior segment surgery but don't know where to begin? Well, you can rely on Eric Rosenberg, cornea and refractive fellow from Weill Cornell Medicine in New York, to be your guide. Let's listen in as Dr. Rosenberg discusses the digital revolution and tells us everything we need to know about the available and soon to be available platforms for digitally assisted cataract surgery.
In the 1850s, surgical loupes grew in popularity due to their relatively lightweight nature and 2 to 3 times magnification capability. Around the same time, surgical microscopes began establishing roots, but adoption stalled for nearly 100 years while the optics and working distance were developed and optimized. Although the superiority of surgical microscopes was demonstrated almost 50 years into their development, surgeons' preference and the popularity of loupes delayed their widespread adoption. With time and continued evolution, including the development of coaxial illumination, hands-free design, and extended depth of focus, modern surgical microscopes have become an irreplaceable commodity. And now, after 15 years of development, another viewing format is available for routine use in ophthalmic surgery. Stereoscopic high-definition visualization systems were quickly adopted by posterior segment surgeons due to their increased depth of focus, higher magnification, and precise focus, all of which augment the measured and delicate maneuvers required in posterior segment surgery. Anterior segment surgeons have been slower to adopt digital microscopes for various reasons, including their price, discomfort caused by the headsets, inconvenient camera box location, requirements for efficient and high-volume setups, and concern regarding visual processing lag of early models. The improved ergonomics, smaller size, progressive teaching capabilities, synchronized intraoperative OCT, built-in digital corneal marking, and phacofluidic overlays, and improved efficiency provided by these microscopes, however, indicate that 3D visualization platforms will be the next evolutionary step forward in our anterior segment surgery. In this article, we provide an overview of the attributes of 3 available or soon-to-be available 3D visualization platforms in order of their emergence in the market. Number 1 is the Ingenuity by Alcon. The second, the Artivo 800 by Carl Zeiss Meditech. And 3, the Bionics 1 from Bionics. The Ingenuity 3D visualization system features 4 primary components: a 3D high dynamic range HDR camera, a 3D 4K 55-inch 60 frame per second organic light emitting diode surgical display, an ultra high speed image processor, and passive polarized 3D glasses. The Ingenuity HDR camera offers true stereoscopic 3D imaging with 2 full HD 1920 by 1080 complementary metal oxide semiconductor also known as CMOS, sensors that do not require alignment, focus, or synchronization. Additionally, the CMOS sensors provide low noise, high sensitivity imaging. The Ingenuity employs an advanced stereoscopic display to recreate binocular disparity, targeting the delivery of visual information to the right and left eyes. Notably, this kind of depth perception is not reproducible with standard analog oculars. When this is combined with passive polarized 3D glasses, the system provides a dynamic and immersive 3D visualization experience, not only for the surgeon, but for all others in the OR, including residents, fellows, medical students, and co-surgeons. The Ingenuity system has several key attributes. Mobility and adaptability. The Ingenuity offers the ability to move the system between ORs and microscopes. The Ingenuity's HDR camera attachment can be fixed to most surgical microscopes, including those available from Carl Zeiss, Meditech, Leica, and Luxor, with ease. Additionally, all components of the Ingenuity can be incorporated into the cart that houses both the image processing system and the 55-inch monitor, which can then be wheeled to any OR within a facility. Along the same lines, the HDR camera box can be moved to a microscope with a slimmer design profile, thereby increasing surgeon visibility around the physical structures. If the operating microscope begins to malfunction during surgery, simply move the Ingenuity to another microscope, which can preserve the surgeon's HD view. The Ingenuity 3D visualization system provides unparalleled detail on all of our operating microscopes. Real-time 3D HDR surgical image optimization. Proprietary image processing technology optimizes the Ingenuity's 3D HDR surgical images in real time. This processing elevates the intensity of the imagery, adding contrast, sharpness, and color. The resulting ability to appreciate subtleties offers many advantages to the surgeon. There is no light saturation with automatic gain, elevating the intensity of the imagery and allowing fine details to become visible in very dim light. Anecdotally, we have found that when as much ambient light is eliminated from the room as possible, up to 3-fold less coaxial light is required intraoperatively. Remarkably, when we need an enhanced view of surrounding structures, instead of turning on the microscope surrounding field illumination, we instead instruct the nursing team to turn on the overhead lights. Ultimately, this leads to a more comfortable patient and less potential light-induced macular toxicity. Although advanced processing comes at a price of time, with lag reported in earlier models, we have not found this to be noticeable during our surgical cases. Feature applications and open architecture. The Ingenuity's smart 3D platform enables the addition of future applications and provides open architecture for multiple digital inputs. In the not-too-distant future, we believe that we will start seeing integrated intraoperative aberrometry in fluid dynamics. With digitization and open architecture, the Ingenuity offers a modular platform that can change along with the evolving nature of our ophthalmic specialty. This platform has the good fortune of having been on the scene the longest. It is user-friendly and has ergonomic setup that is highly customizable to surgeon preferences. The Artivo 800 is the first 3D-capable digital ophthalmic microscope, according to the manufacturer. It introduces the novel digital optics technology, which produces higher resolution optics and provides better light transmission than traditional optical microscopes. These features allow surgery to be performed using lower illumination levels, which translates to greater patient comfort during surgery. There are several key attributes of the Artivo 800. Hybrid mode. Hybrid mode allows the surgeon to view the surgical field using 3D imaging on the screen or through the oculars. If the surgeon wants to use the microscope oculars at any point, the surgical team in the OR can continue to view the image on the monitor, helping to maintain an immersive experience for the surgical team and supporting cooperation among OR staff members. This feature also provides greater flexibility in the OR than other 3D visualization platforms, for which switching between monitor and ocular visualization is time-consuming, can affect workflow, and can lead to mechanical failures. Viewability and image quality. The stereoscopic 3D images of the Artivo 800 are viewed on a 55-inch 4K resolution monitor that provides outstanding depth of field and high-resolution images with natural colors. The monitor should be positioned approximately 1.2 meters from the surgeon to help him or her maintain a comfortable position and the rest of the team to access a clear view. To eliminate the signal delay present in earlier 3D visualization systems, the optical system of the Artivo 800 has two 3-chip 4K cameras that produce remarkably clear images with no lag perceivable to human eyes. Intraoperative OCT. Equipped with intraoperative OCT, the Artivo 800 streamlines surgical decision-making and helps to ensure correct tissue placement during surgical procedures, increasing safety and optimizing outcomes. Integration. Cloud connectivity with the Zeiss Cataract suite allows the surgeon to easily access patient data remotely at any stage in the pre-, intra-, or postoperative periods, improving OR workflow and efficiency. Intraoperatively, the patient's identification, IOL specifications, and phaco parameters can be overlaid onto the real-time image without blocking the surgical view, thereby enhancing efficiency and safety during the surgery. Integration with the Callisto Eye markerless alignment system offers further benefits with information about incision, capsulorhexis, and astigmatism alignment displayed directly in the surgeon's eyepiece. This technology can help cataract surgeons enhance the accuracy and precision of toric IOL alignment, optimizing refractive results. Auto Adjust. This feature is designed to anticipate the surgeon's workflow and optimize visualization by automatically adjusting settings without the need for additional interaction. The Artivo 800 provides ophthalmic surgeons with enhanced connectivity, viewability, and workflow in the OR, optimizing surgeon experience, OR efficiency, and patient outcomes. The Bionics 1 is a 3D visualization system for anterior and posterior segment surgery. It includes a surgical microscope, computer system, and a wearable helmet headset with a built-in 3D display. The technology and design of the system are modeled after those of military fighter pilot headsets that provide pilots with digital and graphic information about the cockpit and the airspace around them. The head position of the wearer can control modification of settings and display changes. There are several key attributes of the Bionics 1 system. Optimized surgeon experience. During surgery, the headset allows the surgeon to use head gestures such as tilting the head up or down and left or right to continue multiple functions of the microscope view in various software applications. The headset displays images in a quality equivalent to the resolution of 4K display monitors and similar to that provided by other current 3D visualization platforms. The projected image size on the headset's display screen is equivalent to a 55-inch monitor placed at a distance of 1.5 meters. The design of the Bionics 1 headset allows the surgeon to have situational awareness during surgery because it enables peripheral vision and because the headset's transparency setting can be controlled. If the surgeon uses spectacles, including those with multifocal optics, these can be worn to support the best possible viewing. Although the headset is currently tethered to the computer system by wire, it will ultimately be wireless, and use of up to 3 headsets per system will be possible. Exceptional imaging. The system is designed with 2 optical channels with a resolution greater than 100 megapixels, which is better than the resolution of an 8K display. With LED illumination, the camera delivers exceptional stereoscopic imaging of the surgical field. The LED illumination supports a wide field view as well as red reflex capability for cataract surgery. Customizable head gesture controls. Depth of field, image focus, image zoom, XY axis movement, and illumination can all be controlled with head gestures. These are customizable functions. Head movements can also control magnification and zoom. This functionality eliminates the awkward maneuvers required by conventional microscope systems, often using the left foot to control these operations. The surgeon thus gains finer control over illumination, magnification, and zoom than is achievable with other platforms. Additional features such as intraoperative OCT can be incorporated into the microscope system during surgery, and this can also be controlled using head gestures. Automated 3D camera positioning. The Bionics 1 3D cameras are suspended on a 5-axis motorized arm that can follow the surgeon's head movements and place the camera in the optimal position for the surgeon's view. The latency of the processing chain from the camera grabbing the image through the image process and fusion to the surgeon's display is less than 20 milliseconds, allowing seamless view with minimal to no latency. Bionics 1 is undergoing FDA regulatory review processes, and the manufacturer hopes the device will be available commercially soon. It will be exhilarating to see yet another 3D visualization system enter the ophthalmic surgery space. The evolution in 3D visualization will continue to improve surgical outcomes and the surgeon's experience in the OR. Cataract surgery is one of the oldest documented surgical procedures, dating back to ancient Egypt and the couching technique. Continual evolution in technology and surgical prowess over the past 300 years has elevated the procedure to one of the most successful treatments in medicine. With each iteration of technique, a unique skill, apparatus, or scientific development can be identified as the driving force behind the changes in how cataract surgery is performed, ultimately improving safety and outcomes for patients. The shift to the use of 3D digital visualization platforms for anterior segment surgery seems inevitable. Each of the available platforms has unique attributes. Ophthalmologists should welcome this digital awakening in the surgical arena, as it will allow us to provide the best possible care to our patients. Innovation can be fraught with challenges, but it will ultimately refine our processes and allow us to deliver optimum outcomes with the most successful procedure in medicine.
That's it for this episode. I hope you'll join me again next month on CRST the podcast, where we'll recap the benefits of dry eye disease management on patient care and business success.